I've been an avid inventor most of my life, with more than 40 U.S. patents, the majority of which are for implantable heart pacemakers. As a scientist and researcher, I had the opportunity in the early 80s to observe a biopsy procedure on a transplant patient, his third one of the 20 needed in his first year following surgery to assess his rejection status. The patient was awake during the procedure, numbed only with local anesthetic, when he looked at me and said, "I'd rather have another heart transplant than another one of these biopsies." I knew right then that I needed to develop a device that could eliminate these dangerous, painful, and costly procedures.
Introducing the Implantable Heart Rejection Assessment Monitor, the IRAM. In 2005, Dr. Scholder founded QRS Systems with three things in mind for heart transplant patients: eliminating biopsies, the gold standard in assessing transplant rejection, reducing morbidity and mortality associated with these biopsies, and lowering the costs associated with the post-surgical assessment of rejection. The company has assembled world-renowned doctors, physicists, engineers, and has contracted with an FDA and ISO-approved manufacturing subcontractor to build its IRAM system. Subsequently, QRS has built, deployed, and tested its groundbreaking technology with stunning results. But don't take our word for it, ask the experts. Today, what method is used to determine if a patient is experiencing transplant rejection?
One of the greatest problems with transplant patients is that they do not get symptoms as a result of their rejection because the transplanted heart is a denervated organ. There are no nerves to the heart, and so patients don't frequently get symptoms from transplant, and so monitoring becomes extremely important, particularly in the first year.
The way that we actually measure rejection in heart transplant patients is that we use usually cardiac biopsies.
That's an invasive procedure that requires placing a catheter or a tube into a vein, taking it down to the heart and taking a piece of muscle out of the heart.
And when you're acquiring cardiac biopsies, you only get a small portion of tissue. So if you don't actually get a smidget of tissue that is actually rejecting at the time of your sampling, you may actually miss rejection when in fact it's already there.
What are the complications of these endomyocardial biopsies?
Use of endomyocardial biopsy to assess rejection does entail a risk. It is an invasive procedure,
which has complications consistent with perhaps bleeding, puncturing the lung or pneumothorax, and the ability of producing an infection or introducing endocarditis into the heart with every single biopsy without actually getting the information you're looking for.
This is a not inexpensive procedure. Costs somewhere around $7,000 is the reimbursement for this per procedure. Perforation of the heart, arrhythmias because you have a catheter inside the heart. So those are certainly some of the potential complications of this invasive procedure.
The IRAM is an implantable rejection assessment monitor. At the time of transplant, it's placed in a subcutaneous pocket in the upper right or left chest area and wirelessly transmits daily data to the bedside monitor while the patient is sleeping. The bedside monitor receives the data and, using its internal phone modem, dials up the company server and relays the transmitted patient information. The QRS Systems server places the data on the company's website, which automatically notifies the doctor if transplant rejection has been detected. What do you envision will be the benefits of the QRS IRAM technology over these painful, invasive, dangerous, and expensive biopsies?
Biopsy is certainly an intermittent kind of measurement. It's done perhaps once a month, maybe 2 times per month, whereas the type of monitoring system that the QRS Systems device allows one to do is daily monitoring.
Well, this is a technology that will allow us to actually assess not hemodynamics, but really assess the myocardium on a daily basis, which may be much more sensitive on a cellular level for picking up rejection before the patient ever has symptoms. And since we know that the degree of rejection is cumulative over the lifetime of a patient, this may make a difference in actually making the patients live longer.
This device will allow us to adjust immunosuppression in post-transplant patients to a level not seen before, because it's a continuous monitoring device, so that we can really, for example, patients with risks of infection or cancer, we can really minimize their exposure to immunosuppression, which may worsen these adverse outcomes.
And this can be done without poking a hole in the patient, without the risk of entering the circulation and all of those other kinds of risks that we talked about a moment ago. This allows that constant monitoring daily.
By God, we've done it. We've assembled a world-class team and developed an implantable device, the beneficiaries of which will be the heart transplant patients of the future.
QRS, eliminating biopsies, improving healthcare, lowering healthcare costs.